Thank you for your introduction. Good morning, everyone. My name is Jeon. I'm going to talk about cortical atrophy differences between Alzheimer's disease and Lewy body-related cognitive impairments across the disease span. This is one of my figures showing cortical thickness differences along with the disease progression. There are two most common causes of dementia. The first is Alzheimer's disease, AD, and the second is the Lewy body disease, LBD. The LBD is an umbrella term for Parkinson's disease and dementia with Lewy bodies sharing common pathological, neurochemical, and morphometrical changes. In 1991 and 2003, Brock and his colleagues described the staging of the disease to classify the degree of the pathologies by performing an autopsy of the brain. These proteinopathies are associated with significant neuronal loss, and it is important to characterize the cortical atrophy pattern for better diagnosis and treatment. As you know, there are many previous studies showing AD and LBD-related cognitive atrophy, but there was no study showing the differences between the AD and LBD over the disease progression. Using a well-established method and better diagnosis, we aim to show how is the cortical atrophy affected differently as the AD and LBD progresses. I will explain a little bit about the study sample and image processing method and filter size selection and the MMSE specific analysis. This study was done in collaboration with Seun's Hospital in Korea. Among the patients who visited the hospital, 3T MRI, clinical diagnosis, and neuropsychological tests were performed. Patients with AD-related cognitive impairments have no apparent Parkinsonism or REM disorder, and all of the patients with Lewy body-related cognitive impairments were confirmed with dopamine transfer imaging for better diagnosis. This is the strength of our data set. Patients with other causes of cognitive impairments, including vascular and mixed disease, were carefully excluded. After the image processing and quality control by MRI, 235 ADs and 230 LBDs were included in our analysis. For the cortical thickness measurement, we used the CBEP processing pipeline developed in our laboratory. Images were registered into ADNI template, which provides better alignments for the patient with significant neuronal loss. After correcting non-uniformity of the MRI, tissues were classified into three classes, then surfaces were reconstructed. They have 80,000 vertices each. Then we measured the cortical thickness by measuring distance between the vertices. We strictly control the data quality based on automatic and manual method. We verified that they were free of MRI artifacts or image processing error to minimize the technical variation. We have confirmed that there are no statistical differences in the QC metrics between the AD and LBDs. We then tested the effect of filter size on the detection of the pathological changes. It is important to note that there are no globally optimal size for the smoothing, and the selection of the size hugely impacts the statistical analysis. Also, patients may have different response to the filter size depending on the disease type or disease stage. Here's our best filter criteria for our data. So it should show the high signal, of course, and we expect to see the early changes in these regions as described in pathological studies, including Brock's staging model. Also, the findings need to be well localized for the disease-specific patterns. So, these are results from 5mm kernel. Colors represent T-scores, and white line bounds significant regions. Let's focus on SCD stage because we are interested in early changes. At 5 and this one is 10, patterns are very noisy, and we do not see anything significant on the SCD stage. At 20mm, there are significant changes in LBD in occipital region, while for AD, there is no change. So, does it mean that the LBD changes earlier than AD? Let's not judge it too quickly without looking at different kernel sizes. At 30 millimeter, we finally could see changes in AD. This is why we have to double check the filter size. The optimal size could vary across the different study questions or MRI or tissue properties and the region of the interest. In this 30 millimeter, the signals are getting much stronger and the pattern seems well localized. This is also a case of the 40 millimeter, but the peak signals are a little bit weaker than 30 millimeter. At 50, we lost the signal in LBD and 60 as well. This may imply that early changes in LBDs are focal, so it is undetectable if the filter size is bigger than 40 millimeters. So, based on the strength of the signal and the localizability, we selected 30 millimeter for the analysis. Okay, let's take a look at AD first. The atrophy started showing in the left entorhinal cortex. As you can see in the first two stages of AD, it is pretty obvious that left side is more affected by the disease than the right side. This has been reported several times in previous studies showing that the left hippocampal area is smaller and more vulnerable. In LBD, cortical thinning started from orbitofrontal cortex and the occipital region. Next, this shows the direct comparison between AD and LBD. Red is AD thinner and blue is LBD thinner. Since this is only three-stage comparisons, we see a lack of detail in temporal resolution. To show more detail in contrast inside the disease stage, we use the MMSE score as a proxy marker for the disease progression. We use the general linear model to test group effects at differentially centered MMSE score with this quadratic model. We estimated the degenerative curves from 4065 patients at 80,000 vertices each. Then we tested group contrast along with the disease progression. This model was used in previous studies showing the AD-related changes in autism or IQ group. For this model, video shown on the top and the snapshot is on the bottom. It shows the group of differences for the specific MMSE score. Red is AD thinner and blue is LBD thinner. This is like a territory conquest game that shows which team is dominant at the specific particular time. Let's take a look closer. Okay, at 27, significant AD thinning starts showing in the left entorhinal cortex and the right and lateral temporal lobe. We observe right entorhinal. We observe left LBD thinner pattern in the orbitofrontal cortex and the occipital cortex. At 25, right entorhinal cortex as follows. At 23, no much change. And 21, left lateral temporal lobe shows AD thinner pattern, and LBD thinning is observed in left cingulate cortex. After 19, the differences between getting smaller and significant regions remains on the left temporal lobe at the lowest score. In overall, the medial temporal and temporal parietal atrophy characterize AD, and the frontal occipital atrophy could be a useful feature for the characterizing LBD. As you can see, this analysis shows much more detail than the stage-based comparisons. In summary, this study demonstrates that the filter size is important in observing changes in atrophy. Your data also may have the different response to filter size depending on the disease type or the stage. Again, the selection should be made carefully before the interpretation. Also, we demonstrated distinct atrophy pattern in AD and LBD across the disease span, which may provide when and where information for the clinicians. We believe that this will contribute to clinical diagnostic sensitivity in the future. I would like to thank my lab members at NMNI and collaborators and patients at Severance Hospital, as well as funding agencies. If you have any questions or comments, please come to my poster today. Thank you for your attention.